Well, welcome everyone to this afternoon. We're very happy to welcome you back and to have two excellent speakers for this afternoon. We may also be joined by Mark Blandford. I will then invite Mark to say a few words and including welcoming David to our event this afternoon. Over to you, Mark.
Good afternoon. Thank you very much, Mary Lou. Hopefully you can hear me. Yes, I see David nodding. That's great. Good afternoon and welcome. My name is Mark Blandford. I'm the Vice President of Seniors Clinical Operations here at Providence Healthcare in Vancouver. It's my pleasure to welcome you to the Fall Dialogue on Aging series session today. As always, I'd like to just say a few words about kind of where we're at. I'm going to introduce our speakers shortly. I guess as a country, as a province, and as a city, we're currently in what we're calling wave 4 of this COVID pandemic. It's going on probably for 20 months now that we've been involved in this. And it continues to evolve and continues to be a challenge for all of us in the healthcare business, as well as anybody working with seniors. I think we're in a much better place than we were the last time I spoke to you. Here in Vancouver, at least, in most of our care homes, we're approaching 100% double vaccination rate for most of our residents. We still have pockets. That's been an amazing feat of science. I think a year ago, none of us expected that. But we have an amazing vaccine distributed to those most vulnerable in our seniors population, which is just wonderful. We have some really, I guess, precedent-setting rules around having our staff mandatorily vaccinated, which is, again, a strange situation for us to be in, but we're there. So in terms of looking after vulnerable seniors, we're in a very good place, much better than we were probably this time last year for sure. Lots of us are hoping that we can start to move away from COVID and crisis management into what makes life better for seniors, for elders. What is it that we can do to start to be proactive about making senior years productive, healthier, happier? So that's why we're very lucky today to have a leader in the field, Dr. David Conn, joining us from Baycrest in Toronto. His bio, I think, is on the website, but he is the founding co-chair of the Canadian Coalition for Seniors Mental Health. And I'm really looking forward to this afternoon's session. Psychiatry and long-term care is a real interest of mine. We're working very hard here at Providence Health to improve how we're delivering services for people with mental illness, substance use as well. And so I'm looking very much forward to hearing Dr. Conn's presentation this afternoon. So I'm going to hand over to him shortly, and I'm going to sit back with you and look forward to the session. So David, welcome to this virtual session, and looking forward to hearing you speak.
Great, thanks, Mark. Thank you so much. And it's a great pleasure to be with you all today over in the West Coast, and I'm talking to you from Toronto. Miracle of technology, but yeah, this has been a very challenging time for all of us across the world, but things are looking up, and certainly in Ontario as well. So I'm going to be talking to you today about preventing and treating depression as we age, and these are disclosures just to say that I don't have relationships with any commercial interest today, that I'm chair of the Coalition's Guidelines Committee, and we've been funded by Health Canada to create guidelines. And I'm also a member of the leadership team for something called the Fountain of Health project that I'll be talking about today, a little bit about, and a project that we did looking at certain tools that could be used by clinicians to promote health amongst their patients. So this is what I'll talk about today, a little bit about happiness and aging, how we can achieve optimum mental health, some guidelines regarding the recommendations on preventing depression, the fountain of health approach, and then guidelines around the actual treatment of depression. Well, Mark mentioned the pandemic, and this is hot off the press. This is an amazing article that came out in Lancet just a couple of weeks ago. The investigators were able to get data on the degree of depression and anxiety across the world during the pandemic. I don't know how they managed to get all this data, but it shows that in virtually every country in the world there's been a significant increase in depression and anxiety, not surprisingly, and overall about a 25% increase in both of those. And this, from the same article, shows the degree of depression and anxiety by age group. And of course, that depends on the population as well. But basically, the wider those bars are, the more depression and anxiety there is across the population. But the colors orange and purple show the increases that have happened during the pandemic. And interestingly enough, of course, it's actually younger people who really seem to be suffering the most in this regard. And there has been a fair bit written about the resilience of older adults during these difficult times. That being said, we know that there's been a huge amount of increased isolation and loneliness and depression amongst seniors. So we're all striving to be happy, and that seems like a tall order in some circumstances, but even if we have moments of happiness, that's pretty good. Interestingly enough, there are studies showing that as we age, we're actually more likely to be happy. Isn't that surprising? There's some studies from San Diego and California where they looked at different age groups, and they actually found, this is really interesting, that although one's physical health naturally declines as we age, the overall sense of well-being actually increases, gets better over time, which seems kind of strange. The researchers come up with different theories about this. One is that older adults may expect life to be harder and to learn to live with it, or they're actually more realistic about their goals, only setting ones they know they can achieve. And another investigator, Carstensen, thinks that with time running out, older people have learned to regulate their own emotions, focusing on the things that make them happy and letting go of those that don't. Interesting. Sasson writes about positive thinking, and these are some of the things you can do to think more positively and to do good things. So look at the bright side of life, have faith in yourself and the power of the universe, associate with positive people. You don't want too many friends who are downers. Read inspiring stories, repeat affirmations that inspire and motivate, visualize only what you want to happen, and learn to master your thoughts. Meditation, mindfulness, these things are all good things and can help us feel better. But what if you do start to get depressed? So there are different diagnoses we use. The big one is called major depressive episode. That's when you've got a significant depression, not just depressive feelings. And then there are, on the right-hand side, there are other conditions that are less severe by and large, usually, although not always. And so adjustment disorder, that means that something bad's happened in one's life and you have some depressive feelings, but it's possible to get over that without any kind of treatment. And of course, bereavement itself, which is so frequent as we age, has its own challenges and may evolve into a depression. So these are the things we actually look out for when we're thinking that somebody might have a significant depression. So apart from depressed mood itself, we look for anhedonia, which means loss of pleasure, the inability to experience pleasure, changes in sleep, usually challenges sleeping, less sleep, but sometimes more. Same with appetite. Most people lose appetite, but some people actually have excessively increased appetite when they're depressed. low energy, poor concentration, feelings of guilt or worthlessness, being really slowed down or restless and agitated. And then, of course, when someone's really seriously depressed, they may actually have thoughts of death or suicide. And these symptoms, you don't need all of them, but if you have 5 out of 9 for at least 2 weeks, we would start to think the person might have a significant depression that might need some sort of help. We're always trying to think about, so why is someone getting depressed? Is there a reason for it? Is there no reason? In fact, some people may actually just get depressed for no obvious reason. At the bottom it says just depressed, don't want to analyze it. But we know that as we age, there are stressors. There are things that are more likely to happen that could contribute to depression. So increased physical illness, chronic pain, sensory deprivation, so losing our vision or our hearing, the actual life changes that retirement brings. Retirement can be wonderful, but for some it can be a really difficult period. Bereavement, social isolation, loss of roles and status in society, and then financial difficulties that are very common as we age. So all of these are stresses that could contribute to depression. In our fields, we like to think of what's called a biopsychosocial model, which means that we don't think there's a single cause for depression, let's say. There might be biological causes, which are more physical in nature and could include changes in the brain or in the body or chronic illness, drug issues. And then there are social, environmental factors that could seriously bring down our mood, as well as psychological factors. So when we teach our trainees, our residents in psychiatry, this is the model we teach them, that they have to think about not a single cause, but really try and understand the person both in the past, in the present, in terms of all of these different factors. And we're always striving, of course, for mental health. And even people who have suffered from, say, chronic mental illness, we can improve their mental health in many different ways. So recently, our coalition, the Canadian Coalition for Seniors Mental Health, revised our guidelines. These are guidelines for health professionals on how to prevent, assess, and treat depression among older adults. So this document is available, if you have any interest, online at the website of the coalition, which is at the bottom there, www.ccsmh.ca. And you can, download or look at the whole document if you're interested. But more likely you'd be interested in some of our other resources that are on the website that are specifically designed for older adults and their families and the general public. So, and there are such materials for a whole variety of different conditions, including depression. So within those guidelines, these are the things that you could find. And I'm going to focus more on the ones in red. So how to prevent depression, and then some of the interventions, whether they be psychosocial or pharmacological. There are lots of people to acknowledge regarding these guidelines, as listed here, particularly Health Canada. Lots of people. This is the guideline update group, and I have to shout out to Laurie Amdam, who's been working with the coalition as a volunteer for many years and is on Vancouver Island. She's a wonderful person, and as well as other colleagues from across the country. And actually, this was the group that put together the original guidelines 15 years ago. So we always acknowledge them as well. So these are the actual recommendations on preventing depression in these guidelines. So there's actually 5. One is to reduce isolation and loneliness. I'll mention what a stepped care approach means. Something called social prescribing, increasing physical activity. I'm sure you've never heard that one before. And then this is for health professionals, that we need to always instill hope and positive thinking when we're caring for individuals, whether they have a mental health or a physical problem. This is the actual wording of the guidelines recommendations. So it says that there are many interventions that focus on reducing social isolation and loneliness. And these have been studied and have been shown to reduce depressive symptoms in addition to reducing loneliness. And a lot of these interventions are group-based, interestingly enough, and there are all sorts of therapies and physical exercise programs and so on and so forth that have been studied and actually shown to reduce the likelihood of people getting depressed. Stepped care is for people who have some depressive symptoms, not an actual illness, but it involves gradually introducing certain interventions depending on how severe the symptoms are. And this has been studied actually in various countries, including the Netherlands, and it's been shown to reduce the ultimate development of depressive or anxiety disorders. And then there's something called social prescribing, which is being trialed now in many countries, including Canada. And this is actually where instead of prescribing medication, the physician or other healthcare professional actually prescribes contact to the voluntary or community sector, the resources in the community. And this has been studied and shown to be beneficial. With guidelines, we're always looking for evidence, research evidence. So we only make recommendations if there's some evidence to support it. And then, higher levels of physical activity are consistently associated with lower odds of developing depression in all age groups. So this has been well studied, and it doesn't have to be, rigorous aerobic activity. Walking is a terrific physical activity if you're able to do that. Even stretching exercises are fantastic. And then finally, as I mentioned before, it's always important for us to instill hope and positive thinking as a therapeutic tool. So I want to talk a little bit more about prevention and risk factors. And although I'm talking about depression, there's a big overlap with dementia and depression, so Alzheimer's and other dementias. So there's a huge movement right now to try to maximize these modifiable or actually maximize the reduction of these risk factors. And if you look at the 9 listed here, a lot of them are physical things that we need to do to maximize the health of each person. Again, physical inactivity is on the list, but depression is also on the list. So identifying and treating depression is also a way of actually preventing dementia, believe it or not. So this is really important. So the Fountain of Health project originated in Nova Scotia and was the brainchild of a colleague of mine, Dr. Carrie Lee Cassidy, who's a geriatric psychiatrist. And with her team in Nova Scotia, they developed this wonderful program called the Fountain of Health. And playing on the term, the Fountain of Youth, of course, but the website is there. There's all sorts of great materials on the website for the general public and for clinicians. And this is a way of helping people to make positive lifestyle changes to improve their health. So the next few slides are actually from the Fountain of Health. So consider this: what non-pharmacological treatment improves the outcomes in heart disease, hypertension, diabetes, arthritis, depression, anxiety disorders, obesity, addictions, and insomnia, and is the #1 most powerful promoter of brain neuroplasticity, that's creating new connections within our brains, which can occur at any age? And what's the single best thing we can do for our overall health? Well, the answer is exercise, increasing physical activity. So the Fountain of Health really promotes the idea that there are a lot of things we can do to improve our health. And the question, one important question, is to what degree do we control our own health destinies? And this might surprise you, but genes only account for about 25% of what determines human longevity. Only 25%. I always thought it was more, but twin studies have carefully looked at this and shown that it's only about 25%. So this is really good news. It means that there's more under our own control. So the Fountain of Health recommends 5 key domains. So positive thinking, social activity, physical activity, challenging our brains, and promoting mental health, recognizing when we have issues and doing something about it. And the approach is simple. You get a baseline, you set one goal, and then you track your progress. So it's a very simple behavioral approach. Getting the baseline, these are questionnaires that are online, or your doctor or healthcare practitioner could give them to you if they're using the Fountain of Health. And there's also an app, which I'll mention in a minute, that you can use if you're tech savvy and use cell phones. A free app, of course. And the goal of setting a SMART goal is really important. What's a SMART goal? Well, it's specific, measurable, meaningful, action-oriented, realistic, and time-limited. So when are you going to do it? And, you know, it's all very well to say I'm going to exercise more, but unless you actually do this, where you actually write down what you're actually going to do, how you're going to measure it, you know, what's the specific action that's required? Is it realistic? Is it, you know, when are you going to start? If you don't do those things, it's just theoretical. And this is not easy. Changing our habits is really quite difficult. And I for one, I should exercise more. You know, definitely. I know I should. I do my best to follow these things, but I'm not always successful. So I know it's hard, but it really can make a change if you follow the simple approach. And you know, ultimately, you set a goal, simple goal, track it, see how you're doing, and then if you achieve that goal, you can set another goal, maybe one that's a little more challenging. And we actually encourage people to start with really small, attainable goals. We want to win. And this is how to actually find the wellness app. But you can get it right off the website, thefountainofhealth.ca. The project that we were funded for last 2 years ago was to try to get clinicians across Canada to start using these tools with their patients. And so it was a pretty big project, and we had some success. And but the hardest thing is also to get clinicians to change their habits, because many clinicians are not used to doing this kind of work around health promotion. So, so that brings us back to depression. So all of those things that I mentioned before, all of those things could benefit us in terms of preventing depression. So everything I've talked about up till now is actually really around preventing depression. I did mention before that there are different kinds of depression and different approaches. And so the guidelines that I mentioned go into all sorts of detail about, you know, if you have this kind of depression, then we suggest this kind of approach and intervention and so on. But even before one gets there, as a healthcare professional, we have to make a diagnosis, and that involves an assessment. So what does that mean? Well, we always start with an interview, and that means getting to know the person, understanding their full history, which would involve their mental health history, if there is one, if they've had a previous depression or some other problem, anxiety, knowing about their physical health, knowing about their family history, what medications they're on, and so on. And that's really, really important, of course. And then in many cases, we want to get history from a family member or other caregiver as well, if possible. It's not always necessary, but for some older people, it really helps to get a collateral history, as we call it. And then we do what's called a mental status examination. We try to understand how the person thinks, how they're feeling, understand the way that they think, as well as a cognitive assessment, which means memory and other brain functions. So we use various tools to do that, often very quick tools that might be done in 10 or 15 minutes. That's important to us as well, to understand if the person's having any difficulties with memory or other cognitive problems. We might need to do a physical exam, not always, but if we're trying to rule out certain underlying physical conditions, that might be necessary. Usually we'll do some blood work, at least at the beginning when we're seeing someone for the first time, to rule out certain illnesses like if your thyroid gland isn't working properly, if it's underactive, which is very common, that can cause depression. So we need to rule out any underlying physical condition, if at all possible. Low B12, vitamin B12 could also be a factor. In some cases, we'll do brain imaging, but not always, only if there's some real reason to do it. And then we always assess safety, including driving safety, which gets people nervous. In Ontario, physicians have to report someone to the Ministry of Transportation if they suspect the person may not be able to safely drive. And that's a whole other talk and a really challenging issue, and a really controversial area, of course. So, so I did want to talk a little bit about how we actually treat depression. If someone has a significant depression, then what are the possible interventions? And so the first thing we like to think about is not medication. Again, we're talking here even if someone has a fairly significant depression, sometimes they don't need medication. They may well respond to talk therapies that we call psychotherapy or other psychosocial interventions. So the guidelines emphasize that we don't always start with medications. So, and these are some of the, I've only taken a few of the actual recommendations because it's quite a large document that has all sorts of different recommendations, but just so you can get a snapshot view of the kind of things that are in the recommendations. So this one says that there's actually promising evidence for exercise and mind-body interventions such as Tai Chi, yoga, mindfulness-based stress reduction in reducing depressive symptoms in late life, either alone or in combination with other therapies. Physical activity in the form of exercise is an important non-pharmacological approach. So not only is it helpful to prevent depression, but it can also be a treatment. So people who are depressed feel better when they exercise. And then clinicians should use their judgment in recommending the type of exercise and duration, taking into account other illnesses, physical capacity, and level of motivation. So there's a lot on that recommendation, but it's really important that clinicians consider this range of different interventions and make recommendations to their patients. And then it talks about the more conventional psychotherapies, and there's a whole range of different talk therapies. Probably the most well-known is what's called CBT, or cognitive behavior therapy, which can be for individuals or for groups. You can have group therapy using that approach. Another popular approach is called problem-solving therapy, PST. And so these particular types of therapy have been well studied in older adults and found to be very effective. So even for someone with a significant depression, a course of CBT could help them feel a lot better and may be quite effective, particularly if the depression is reasonably mild. And the guidelines actually say that these types of therapies should be made available to older adults with depression in diverse settings across all regions of Canada. So this is really an advocacy type recommendation, because often it's hard to find a therapist, especially one that's covered by the health plan in your province. So, so we make this recommendation, and we like to advocate for more services for older adults as part of what we do in the coalition. We mentioned that there are other therapies that have been studied and seem to work as well. And finally, we suggest that therapies can actually be delivered virtually through the internet. And there are studies showing that they seem to be, for some people, they may be comparable in effectiveness to face-to-face treatment. And of course, this improves access to services for individuals in underserviced areas and those with mobility issues. So, and of course, as Mark was saying at the beginning, the world has changed during the pandemic. And so virtual assessment, virtual care has become a mainstay for us during the pandemic. And many of us are now delivering a lot of our care and assessments virtually. Now, I've always done some virtual assessments. I consult to the far reaches of Northern Ontario, and I've been doing that for almost 20 years, which is, and that's using older technologies. But fortunately, we've been able to do that now for 20 years. So the fact that virtual assessments and care are now mainstream is really just catching up with what's been available for many years. And a lot of health professionals have suddenly, realized that this works, especially in areas like mental health, where most of what we do is talking. And then finally, we do talk about antidepressant medications, of course, and there's a lot of advice for clinicians about how to use medications, which ones may work, which ones, if the first one doesn't work, what do you do next? What medications you might need to combine? So there's a lot of detail in the guidelines about this. But just to say that we actually do recommend a couple of particular antidepressants as first line, but then we also say that there are many others that are also very good medications. And we give advice about, that for older adults, we always need to be aware of the potential for side effects and minimize the risks. And we don't want there to be drug-drug interactions. So that's really important and something that we strive to use. So we strive to use the lowest amount of medication possible and choose medications that are the least likely to cause side effects. Really important. And we stress as well that if someone's being started on an antidepressant, that they need to be seen regularly to assess their response, the side effects, to titrate the dose, and that in addition to medication, everyone needs support, supportive psychosocial interventions, as we call it, as well as monitoring for possible worsening or agitation and suicide risk. You may not be aware of this, but older adults, particularly older men, are very vulnerable to suicide and have very high rates of suicide. So that's something we're always very cautious about. We do make some recommendations about the models of care. This is for clinicians, so they understand that there are a number of things that we believe are really important. So collaborative, interprofessional care can be really helpful, particularly in primary care. There have been a lot of studies showing this. And so having a team approach can really help. And we recommend that, again, that going back to virtual care, that's fine, but we also suggest that this virtual care needs to be senior friendly because some older adults really struggle with technology, and they need to be supported in this, and but not the group here tonight on Zoom, obviously. Finally, there are these resources that are available on our website, including in different languages. And you can join the Canadian Coalition for Seniors Mental Health for free. And if you do, you just sign up on our website. And if you do, you get all of our materials and updates, and we'd love to have you on board. It's not just for health professionals, it's for anyone who would like to help out in this area of seniors mental health. And Claire Checkland, who's in Ottawa, is our executive director. So thank you very much. I'll stop there and open up for any comments, questions, and so on.
So just a question there, David, that's more general. Thank you for that. Will the presentation be available to the public? And yes, we will have a recording up on the website, and the resources that were just shared by Dr. Conn will be in the newsletter that follows the event with a link. So you don't have to worry about capturing all those wonderful details. Those will be passed along. If there are any other questions, feel free to just pop those in the chat. And we can try to unmute as well.
I can see there's a question about nutrition from Alberta Rudolph, right? Oh, it's a direct message to me, so you might not see it, but thank you for that question. So good nutrition is definitely important. And I didn't say much about it. I think we're still learning about what is optimal in terms of a healthy diet. Obviously, there's been a lot of work around what's called the Mediterranean diet in terms of optimizing health, and which involves the things that we already know about as being really healthy. So lots of fruits and vegetables and whole grains, and not too much red meat. A lot of fish. Certain fish is really excellent. The Mediterranean diet tends to include a tiny bit of red wine. That's a whole other talk about, alcohol and whether a tiny bit of alcohol is actually good for our health or not. That's still the subject of some debate, but there is some evidence that tiny bit of alcohol is not such a bad thing unless you happen to already have significant memory problems, when it wouldn't be a good idea. And hydration. Alberta says, yes, staying hydrated. And a lot of healthy diets do include, a certain amount of water. That's really important. So absolutely, nutrition is important. And obviously trying to maintain an optimal weight is important. And, avoiding too many substances or other kinds of drugs that may not be good for our health. And I think I did see there was another, there was another direct message to me that said, do you work with clients in care homes? So yes, most definitely. So I work at Baycrest in Toronto, which we have a 470 bed long-term care home, and which I think is the biggest in Ontario. So, thinking about depression and long-term care, the rates of depressive symptoms and depression in long-term care are very prevalent. And so we have a lot of work to do to help people in long-term care feel positive, feel good. And so, again, a variety of interventions can help, including recreation and keeping a person active and busy, and with meaningful activities, with enjoyable activities. And that's where, of course, it's been so difficult during the pandemic in long-term care. Again, things are getting better now, but it was really rough, I think, in the first phases of the pandemic, with people being so isolated. And we use medication too if someone has a serious depression. most definitely. Is it okay if I keep reading out the questions?
Absolutely.
Okay, because I think most of them have been sent to me directly. So, and there's a question here that says that if you live alone and have no one to talk to, how do you communicate to yourself? And that's a very, very interesting question. I'm not sure I really have the answer to that, except I think we all have a dialogue with ourselves. But if you live alone, that kind of dialogue is obviously, we talk more to ourselves when we're on our own. And that can be a good thing for a certain period of time, but I think we don't, but it can be challenging, I think, if you live alone. I think feeling some sort of connection with other people for most people is really important. You should note there are some people who don't need other people as much as others. We're all different, but I think the majority of people want to have some human connection. And that's where it's been, again, difficult during the pandemic. And so again, there are many ways to connect with other people, and the good old telephone is fantastic. New technologies have really helped, so I won't say too much more about that, except to say it really is an important issue. There's a question about what is the cost of delivering this interpersonal approach compared to the old model? How can this be incorporated into our models for institutions? So, yeah, I think that it depends on what the old model is, you know, and I think having the right level of staffing and the right mix of staffing, particularly in long-term care homes, is a critical issue. In Ontario, the government's just promised to increase the number of hours per resident in long-term care up to 4 hours per day from the current number, which is, I think, around 3 or just below 3. So that's a lovely promise from our provincial government, and it's supposed to be implemented over the next 3 years. So that will really help, because I think staffing levels are often inadequate. I think having the right staff, having good training for staff is really important. Having access to specialists is important, but I think that is important. But I think having good trained staff locally is just as important. But being able to deliver psychotherapy, that costs money, and then, you know, it's easier in the doctor's office to just write a prescription for an antidepressant than to actually find a therapist. In some countries like Britain, they have actually created an army of CBT therapists because they've realized that that CBT is such a good approach for treating depression that they need to spend more money on this. Question about, is there any correlation between dementia and depression or vice versa? Thank you for that question. Yes, there is a strong correlation. So people who suffered from depression during their life are more likely, about twice as likely, to develop dementia. And again, that's why we think that treating depression through life, identifying and treating it, is so important. It's one of the reasons why we think it's so important. And then if you have dementia, there is an increased likelihood of having some depressive symptoms as well. So and that should be identified and treated. These wonderful questions. What an amazing group you are.
Dr. Conn, I wonder, we're probably about the last question, if you don't mind.
Okay. Yeah, you bet. I think it looks like we could go on for hours. This is wonderful. The next question was, I mentioned interprofessional teams. Can you say more about which professions, and if you have any idea about how they could work together better to promote the fountain of health? Well, I think all health professionals could actually work on promoting the fountain of health. I think nurses are critical because nurses play such a pivotal role right across our healthcare system, whether it's in primary care or in hospitals or long-term care. I think that social workers, occupational therapists, all have a critical role. Psychologists, of course, who have so much to offer, and so many fantastic therapists or psychologists. So I'd say, all of our professional staff could benefit from working together collaboratively and using an approach like the fountain of health. So I'll stop there, but I wanted to thank you all for listening and for those great questions. And I'm happy, I can give you my email if you have any sort of thoughts afterwards or questions. Happy to please get in touch with me. It's dconn@baycrest.org.
Lovely. Thank you, Dr. Conn. I'm not sure, I know we're having a little bit of a technical challenge here, whether Mark and Mary Lou will pop on for a moment.
I can pop on for sure. David, that was excellent. I'm glad to hear you talking about the interdisciplinary. I'm an occupational therapist who's worked in multiple geriatric psychiatry teams, and it's a true team effort, as you say. I also have taken note of the exercise thing.
I know.
I think I'm definitely many of those things you talked about. I don't think I'm depressed, but I've certainly eaten more, exercised less, and I think that's the same for many of us that work at the front line. But
Yeah.
it's time to put it right. Anyway, I'm sure that was fascinating for me. Some things I knew and some things I didn't, particularly some of those new studies. But thank you very much indeed for taking the time. I've realized that it's probably close to supper time for you.
Yeah.
So we'll let you crack on and have some supper, and look forward to talking to you again. Thank you once again for your time.
Thanks, Martin. Thanks again for the invitation.
Yes, thank you, Mark, and thanks again, David. That was just wonderful, and that is one of the pluses of our Zoom, is that you can join us from Toronto and still get home for dinner. So, thank you very much, David.
Will I get started?
Well, I'll just welcome you first.
Sure.
Very happy to have you, Dr. Janet Koo, with us this afternoon. And it's such an excellent topic that you have, just so timely. And for those of us that have had the pleasure of having you share your knowledge with us, we're very excited to have you with this group today, and help us learn more about how to keep healthy during this challenging time of COVID. So over to you, Janet.
Thank you, Mary Lou. So happy to be here. Thank you. So I'm Janet Koo. I'm a geriatrician, a physician in geriatric medicine. And I work primarily at Providence Healthcare, St. Paul's mostly, but I also have a clinic at Mount St. Joseph's Hospital in East Vancouver. And I've been actually doing a lot of COVID response over the last year and a half, as most of my work is now administrative. But my home and my heart is still with geriatric medicine, with older adults. So I wanted to bring to you today some thoughts that I have. I don't have a lot of slides. So that will leave a lot of time, hopefully, for questions. And I wanted to talk to you about the impact of the pandemic on specifically BC's older and Canadian older adults that go really beyond the unfortunate death and sickness from the illness itself. Be able to identify the risks of the pandemic and give you some tips that are grounded in healthy living for older adults to maintain physical and mental health within the context of the pandemic. I have no commercial interests at all, and I will not be discussing any off-label agents. So this is a photo from 1918. That was our last very large pandemic. So it's 103 years. I don't think people, I mean, it's gone from everyone's sort of common memory, but now that we're having another pandemic to the same sort of global scale that happened then, we're sort of looking back on this pandemic and looking at what they did then and what we did now. More people died in that pandemic than have died in the COVID pandemic, but it did completely upend everything. And the Great War probably, it changed, it probably ended at that time, partly because of different countries, you know, sort of dealing with the influenza pandemic in a better or a worse way. Interestingly, I was looking through a lot of pictures of the pandemic then, and I couldn't find anything with older adults in it. So I don't think that was sort of thought about. The influenza pandemic of that time was mostly of young people. Mostly young people died, children, young men and women. And so older adults, you know, it's a whole new thing to have a disease like this that mostly affected older people. So this is probably the key slide I have. And now we're talking about the fourth wave of COVID, but these are the other waves of COVID, is that you have the initial wave of the disease itself. So people getting sick, people dying of COVID. And it was, you know, particularly bad in our second wave, which was last summer and into the fall, when we had the nursing home outbreaks and a lot of older people that were getting very ill and unfortunately passing away without a lot of treatments. At that time, and even now, we still see some impact on our other resources. And so even when the sort of the cases come down, like we're seeing in the Lower Mainland right now, people still are in hospital for quite a while. And if they're taking up beds in the ICU, if they're taking up beds in the emergency department, other people with non-COVID conditions are impacted because we didn't really plan our services to take that into account a few years ago. Then there's the other waves that we're only starting to really think about. I think people have been aware of them, but there's been so much attention on those first two impacts of COVID that we really do need to still think about the other impacts. We have seen interrupted care on chronic conditions. When people started coming back to the hospitals, and our cardiologists were saying, for instance, when people are showing up with chest pain or a heart attack, they're worse than they would have been before the pandemic. And so people were either unable to see their doctors, were anxious and scared to go to a healthcare facility, may have stopped taking their medications, may not have been able to get their symptoms sort of addressed. And so they are now sort of worse off when they do finally come and see somebody for their chronic conditions. So that's certainly a problem. And then the lockdowns and the isolation that we've had to put people in has caused, across every age group, psychiatric trauma, increased levels of depression, increased substance use, increased levels of mental illness, and we're seeing very high levels of admissions in our psychiatric wards for all sorts of different conditions. People had some economic injury. I think Canada was pretty lucky. I think we did relatively well. Now BC has definitely bounced back, but a lot of people did lose their jobs because of COVID, and some companies shut down. Servers, hotel and tourism industries were all laid off, and so that was very stressful. And then other people like healthcare workers, first responders, other folks have been very burnt out. What we're seeing is nobody took any holidays. You couldn't go anywhere. People quit. Some now with the vaccine mandate, a few people, we've had some people have to quit as well. I think it's not too bad, but people are not willing to work overtime. They haven't had any holidays, and they're just tired. The BC CDC actually put out a questionnaire to all BC residents. And last year, when the pandemic was just sort of getting going, sort of late spring, they had about 400,000 people responded, which is like a massive questionnaire about everything about their health and their habits. And this year, they've just completed another round of the same questionnaire, and it's almost 250,000 people from all walks of life and age groups. And just picking out some of the few findings that they've had, they haven't published this just yet, but it will be released fairly soon. A third of residents in BC reported worsening mental health, whether it was loneliness, depression, anxiety, whatever. And over 40% reported that either they couldn't see primary care providers, or that they were still anxious and not going to see their GPs or other care because of COVID. And that was just in the last couple of months. There was also increasing use across most age groups of alcohol, and of significantly cannabis in the younger age groups. So there's a lot more data in that questionnaire, but that was a couple of things I thought were particularly interesting. What about seniors in particular? And this data is actually from last year. It isn't even from 2021. And what we were already seeing in seniors is a number of things that was sort of beyond COVID. The first thing is that those that unfortunately have COVID. We've all heard of long COVID, so lung issues, shortness of breath, liver issues, and also mental issues, memory issues, etc. We've seen that. It seems to be right now. Our clinics are seeing a lot of sort of middle-aged people, because of the way COVID was handled in BC. Most of our COVID is skews to the younger age groups. Most are fine, but some people have these post-COVID syndromes, and I've seen this in older adults. I have one patient who he said he had COVID 3 months ago. He says he has no appetite, and I think a lot of that is actually COVID. He's still recovering, even though he made it through. What has been seen in some other countries is that although high energy fractures, these would be, say you get in a car crash and break your leg, those go down over the pandemic because people aren't driving as much. But low energy or fragility fractures, so falling down at home or in your bathroom, this actually didn't improve. And we're going to keep an eye on that, because it may have actually gone up because people were at home and not exercising as much. Delayed treatments and surgeries. We know there's lack of social and group activities, and I've talked to my colleagues, the geriatricians in BC, and it's a common story. As soon as the adult day programs shut down, the community centers shut down, people's health deteriorated. home support was less consistent, and that also impacted people. A study from China, they looked at psychological impact, and 50% of seniors said it was moderate to severe in terms of their psychological impact. They complained of loneliness, poor nutrition and weight loss, poor cognitive function, and overall function, and increasing frailty. So this has already been seen in the literature. There's a lot of impacts, and they go way beyond one virus itself. So what can we do about it? Well, first of all, things definitely have changed, and it's all about the vaccines. And we hear about the vaccines every day. The long-term care residents now are getting a third dose, but now we're getting some data on the effectiveness. And these vaccines are remarkable. They really are. We've never seen vaccines this effective, especially when you think about sort of, okay, we have a new disease, make a vaccine. To get that out so quickly and then to have them so safe and so effective is really quite remarkable. So across the entire BC population, these vaccines, if you're fully vaccinated with 2 doses of the mRNA or the AstraZeneca vaccine, has 95% effectiveness against being in the hospital. So you may still get COVID, but the chances of you ending up in the hospital are now only 1 in 20, right? Okay, compared to what it was before. And even against an infection, it cuts your risk of even getting an infection down if you're exposed by 90%. So then there was really no difference in effect with seen, and we're looking sort of the subgroups, they're looking at that more carefully. But it really, between ages sort of, 12, which is where we start, to age 75, you don't see any significant difference. So if you have a relatively normal immune system, and even if you're an older adult, if you're a community dwelling, a healthy adult, a relatively healthy adult, the vaccines are remarkably effective. Where we see that start to dwindle are people that have poor immune functions, or if they are very frail, for instance, those people in nursing homes. Okay, and there was really, they studied it when it was mostly the alpha, the original wild variant, and then recently in the last few months, 2 to 3 months, it's been all Delta in BC, and there was no significant difference between those different variants. We don't have so far any really worrisome additional variants. I'll never say never, because COVID is a wily vaccine, a wily virus, but right now, Delta has been the worst one we've had so far. So we've got vaccines, which is pretty well a miracle substance that we have. So that's fantastic. So, sorry. So what can we do to maintain our health then? Knowing that we have effective vaccines, that we're pretty well protected, not 100%, nothing's 100% in life, and there's no guarantees. COVID is still around. We still have a fair number of cases. It's definitely, especially in the Lower Mainland, with our good vaccine coverage, it slows this virus down so that it doesn't spread like wildfire like it did before we had the vaccines. But you need like over 90% coverage to really see that slowing down. It's like throwing sand in front of someone skiing. That's what it's like. You still ski, but you can slow it down. And what I'd like to propose to you out there is that it's about balance as an older adult. Definitely, even as a younger adult, but particularly as an older adult, because vulnerabilities go up. So it's all about balance. There is risk of COVID for sure, but those have diminished over time with the vaccine, and especially if you're fully vaccinated and a normal immune system. There are those other negative consequences that cannot be overlooked. So the first thing, and I think Dr. Henry is actually a very good communicator, and I know a lot of people admire her. She has said over and over again, and this is still true with all the new things we've learned, outdoor activities are safer in terms of COVID transmission, okay? From droplets and little tiny aerosols, they get blown away when you're outside and you have good, or you have very, very good ventilation, okay? So you see the differences between outdoor activities and indoor activities. Just spending 15 minutes in an enclosed area with someone who's infected, you're probably going to get COVID. You can be with a large number of people all talking. If you're outside or in a very, very ventilated area with a lot of fresh air, you'll see that the attack rates are very low, unless you're like right against each other talking in each other's faces. So outdoor activities, and this photo shows people doing exercise outdoors, is particularly safe, really. There's still, you know, if you're by yourself, definitely completely safe. Outdoor activities are definitely safer than indoor activities. But also, we need social contact. I know some seniors that basically walled themselves in when COVID started. They didn't want any contact with anyone. Maybe they would go on FaceTime, you know, or on the telephone and talk to people. They thought that would be okay, all right? That did not work very well for a lot of them. Not having, we are social beings. And if we don't see people, if we're not around them, even, and virtual is just not the same as in person, okay? If you don't have physical contact with other human beings, your mental health will suffer, your cognition will suffer. You can see how people's memory and thinking suffers, and your overall psychological health in terms of your mood, your sort of willingness to do things goes down. So again, it's a balance. Yes, people are dangerous, right? They could be carrying something nasty, but they also give us a lot of benefit. And we've got to balance, you know, what do you need? You do need some physical and social contact with others. We know from both the literature as well as from anecdotally from what I've seen from my patients, meeting new people is actually more stimulating than seeing the same people. So, you know, I have people that say, well, I see my spouse all the time, all day. I live with that person and I see them 24 hours a day. But as soon as you add in new people, or people they don't see very often, their whole psychological and their often their cognition improves. It's extremely stimulating to have newness, even if you're 90. Okay, having the same thing every day for months and months and years is not very stimulating for your brain, even at very old age. At a very old age. Okay, so new people, new activities, new learning, these are all good for your brain and good for your well-being. Here's a lady drinking a glass of wine. I myself really love wine. Okay, a little bit of wine is not a bad thing, but just wanted to caution folks. You know, most older adults in BC don't use that many street drugs or even cannabis, except for maybe for some pain. But alcohol use is pretty prevalent, and you want to be careful because a little bit of wine is not bad for your heart, not bad for your arteries, probably not that bad for your brain. Once you get over a certain limit, it's actually a depressant rather than any sort of stimulant, and can cause falls, can cause further cognitive issues. So really moderation in your alcohol intake. Diet is always important. People say, well, what should I eat? The picture on the top is a Mediterranean diet. So fish, nuts and other kinds of proteins, lots of fresh fruits and vegetables, okay? Whole grain, sort of other whole grains, that sort of thing. A varied diet. Fish is particularly good. Don't forget your protein, okay? Fish is great. Red meat and other white meats are okay, not too much, but you got to have some protein there. Soy and other nuts also particularly helpful, and then varying your vegetables, fruits, and making sure you have enough calories every day. Down on the right is yogurt, and not to forget dairy products if you can take them, and not to forget vitamin D. Vitamin D is still one of the sort of vitamins that it's like, yeah, we definitely need this. In northern countries, a lot of older people are vitamin D deficient. It's not worth checking because it's a very expensive test. We know that especially fair-skinned older adults don't sort of, where we sit in the globe, where the sun hits us, we don't really get a lot of sun. We don't get a lot of sort of vitamin D coming through our skin. So the only place to get it is from our diets. And food is a better place to get it than necessarily taking pills. Although the supplements are okay, but definitely I would also add in some vitamin D rich foods. So that would be dairy products, yogurt, salmon, some green leafy vegetables. Okay? So really important for overall well-being. And then getting in to see your primary care doctor. I've talked to some of my colleagues about, we're specialists. We specialize in things like Parkinson's, Alzheimer's disease, multiple severe heart and lung diseases. We're seeing a lot of skin lumps and bumps. And what we're hearing is that, well, I can't get in to see my GP, or, it just seems like an awful lot of effort to go through the sort of the process of getting in to see them. And I've got a thing on my back. All right. So we're not that good at looking at people's skin, but we do the best we can. We're working with the GPs to really try and get them to go back and start seeing people in person. I think this is really, really important. And you have to put in that effort to go and see your primary care provider, especially if you haven't seen them since the beginning of the pandemic. Any worrisome symptoms, little things can be actually red flags for something serious going on, and you don't want to miss that. So anything that you've sort of let lapse, any lumps or bumps or blood in funny places, this needs to be looked after now. And don't leave it too long, because we've seen people come in very sick in later stages of disease because they didn't get it seen soon enough. Are you losing weight when you're not meaning to? Is your memory, are people thinking your memory's getting worse, or you're feeling like your memory loss is worse, especially if it's affecting how you're functioning? Are you falling, or are you falling more than you did before? How are your bones? Do we know how your bones, if they're healthy or not? Have we looked after have we checked your blood pressure? Have we thought about whether you have diabetes, or how's your diabetes control? For some people, what's their cholesterol? And then the immunizations. So everyone's been talking about COVID. Flu immunizations have started this week. So get out to your pharmacy. My mother just texted me and told me she got hers today, so I'm very happy. Other immunizations, they're all actually not that, you can actually take a whole bunch of them at once. So don't worry about that. Flu and COVID too. Shingles vaccines, I recommend that for everybody to think about, because shingles is a horrible disease if you get it, and one shot and you're protected. Pneumonia vaccines as well. We are being warned that we might have a really bad respiratory season if you have any asthma or COPD. making sure you have your flu vaccine and your pneumonia vaccine as well. And then talking to your family doctor about anything like goals of care, advanced care planning. I always say that's important in case you do get sick. So those things, need to be done at some point. So please, especially if you haven't seen them in a while and there's any symptoms or any chronic conditions that you have, get back in touch with your family doctor or other primary care provider. So that's it. I mean, it's not really rocket science. It's really a lot about healthy living and looking after yourself, and it's about balance. COVID is not nice. I've seen it. I've seen people very, very sick, but being isolated and locked down, that also has sequelae, and you can't discount those either. The vaccine is effective, so we're in a much better situation than we were a year and a half ago. And boosters, the third doses are probably coming at some point. I don't know when, if it's going to be by the end of the year. Seniors will probably be one of the first, again, in the front of the line to get a third dose. So balance those risks, particularly if you're really scared of being around other people, then outdoor activities are definitely the safest. Physical activity is, sorry, I didn't talk that much about physical activity before. It is really, really important. We've had a lot of people that said, I did all of these things. The pandemic hit, the pool shut down, so I didn't go there. I stopped playing, table tennis or whatever, and they start to fall. They start to lose weight. They start to feel depressed. They get constipated, like all sorts of terrible things, and really all because they stopped doing physical activity. It is like the best medicine, better than any pill we've got, okay? Accessing your healthcare providers and being careful about your nutrition, good nutrition, and being moderate with your alcohol. That's my message for today, and I'd be happy to answer any questions. PPE use by seniors. Not sure, sort of, I could talk all day about PPE use by seniors. We still have a mask mandate for indoors. I don't know how long that will last. The cloth masks, if they're 3 layers, so the ones that you buy with the cloth and then you put the filter in and keep the filter clean, those are good. And then the anything that's sort of 3-layer or K95 for if you buy the disposable ones. Is it different between seniors and younger people? No, there's no difference. The thicker the mask, you want a good quality one, whether it's cloth or paper. The biggest thing is probably fit, okay? And that is something that you might want to think about as a senior. If your face has changed, or you have some sort of sinking in of your cheeks, because of your teeth, that sort of thing, any changes with that, you just want to make sure that the mask fit nicely over your nose and there's not a lot of sort of gaps on any of the sides. So just check that out when you're using any PPE. So masks are the main thing. We use eye protection in the hospital and gowns and that sort of thing, but there's not, it's pretty weak evidence that makes a big difference. It's about masks. This is a respiratory virus, and so it's your nose and mouth that are the most important. Thanks, Alberta. Good question. Any other questions?
Feel free to pop any questions in the chat if you have any.
Thanks, Alberta. Yeah, balance. is about balance and risk, for sure. Do we have any other?
All right, well, I think we'll turn it back to Mary Lou.
Oh, 2 shots of shingles are required. There's 2 different kinds of shingle shots, I believe. The basic one is 2. Yeah, exactly. It is a bit of a. It actually causes more soreness than the COVID vaccine. I will warn you if you haven't had it yet, but it's nothing compared to actually having shingles. Shingles is really, can be really nasty. We've had people end up in the hospital, and it can cause years of pain. So.
So if there's, in the meantime, as we're waiting for another question, I'll just ask you to, to further comment on what you found, that the stories that you told, what you found about how the decline there was in something as what we would say as simple as physical activities, right? It became not so simple during COVID, but that really is quite amazing. All of the research that consistently comes out. And Dr. Conn in the session before talking about depression and how significant physical activity was in that regard. So want to just say anything more about how that is so, it's really like a wonder drug. So
it is. And I was really shocked. I had people that were like 70. These are not old people, these aren't, and they weren't frail, but they stopped doing their regular physical activities, and they definitely deteriorated significantly. Like it's such a strong effect and so obvious. You say, well, when did you start having poor balance? When did you start losing weight? When did you start getting more constipated? They can almost time it to the day that the pool closed and they stop doing their exercises. It is, like I say, it's like, it is a miracle drug, but it's also something you gotta keep up. Yes. Don't use it, you lose it. Absolutely, Alberta.
Well, talking about risk and balance, that kind of leads us specifically to our dialogue on aging and our public presentation sessions, and how in the past we used to be always in person for the last many years at Van Dusen Gardens. So, a lovely environment, coming together, enjoying the speakers, of course, but very much people just enjoying being there with others and, having that opportunity. So when COVID came, we moved to our first time ever to move to virtual for these dialogue on aging sessions, and so now we're kind of at the border again of or all when you talked about balance and the issues. We'll be thinking really carefully about when we can resume in person again, and we'll be kind of following Dr. Henry's guidelines in respect to that, and your thoughts about balancing everything. So I don't know if you have anything further to comment about that, but that our virtual presentations were kind of just in alignment with the COVID.
Yeah, and that's been a hard thing right through the pandemic, and I know Dr. Henry has really struggled is this balance. We know that when kids go back to school, there is going to be more infections, right? And some of their parents are also going to get sick. But we have to say, well, how many people are going to get sick? Hopefully they don't end up in the hospital. Hopefully they don't, and God forbid they die. But the downside of not, and they saw this with kids, is people regressed in their academics. The whole year, their reading, their math skills, like the whole year was like wiped out. So there's there's been this balance right through this theme throughout the pandemic of trying to balance the other effects of lockdown and restrictions. And it's become very clear that it's a really fine line to walk. It's not easy, and you hate seeing people getting sick, but we've also very clearly seen people suffer from the other things. We see it every day at the hospital in terms of people coming in because their depression is out of control, because they've left their heart disease too long, that they have fallen and broken something. So it is constantly that balance for yourself, for your family, and for society.
Yes. Yes. And thinking particularly about the older age group, 75, 85 and older, where you mentioned those in long-term care are now getting their boosters already, and perhaps, as you said, that information hasn't come out, but perhaps the older adults in the community will as well receive a booster. That seems like a possibility, right?
It's a strong possibility, I would say, and so some provinces, and obviously the U.S. has already just gone forward with it. So I think that's good. I think that the benefit from the second to the third dose is probably not anywhere as great as the benefit from the first to the second. Once you get to that second dose, it's like pretty darn good, and then you're just adding a little bit of icing on top if you get a third dose, really. And I think a lot of this is about the waning immunity. The other thing is that immunity is, and I'm not an immunologist, but I've learned a lot about the immune system over the last year and a half, and the immune system is very complicated. So even though people will say, well, my antibodies are dropping, I'm in a study where they're actually measuring our antibodies, and yes, it has dropped from the first dose now till now. The immune system is very complex, and there's different cells in the immune system. And there's memory cells that remember COVID or from that vaccine. And so even though it's not making antibodies as actively by 6 months or 12 months after you've had the vaccines, if a little virus starts floating into your system, it will probably immediately say, oh yeah, I remember that COVID vaccine, and I'll start to activate the immune system to deal with it. And that's why just saying that immune antibody levels go down isn't the whole story. We do see that about 6 months out, in other countries, maybe it sort of rises a bit, but actually we haven't actually seen that yet in BC. And other countries have very different cultures. A lot of people are getting very excited about Israel in terms of, because they were one of the first countries to sort of mostly vaccinate everybody in their country, and then 6 months later they were starting to see an increase. But it was the same time that Delta hit the whole world, right? So this is a slightly different virus, and so sort of teasing that apart between, was it really the vaccine not working anymore, or was it really it's a new virus that was slightly different? And then people's behaviors, that was the other big thing. Because it's not just the virus that affects whether you get infected. It's your own behavior and how, if you don't wear a mask and the person that you're with sort of gave you a huge dose of virus, it's very hard for you to mount enough protection to actually not get a case. But the vaccines still protect you against getting really sick and dying.
Well, as you know, we we are recording your session, and it will be up on the website, and people attending can, let friends and family know as well. And I'm thinking of there are a few people that let me know directly that they were sorry they weren't able to come, and they really wanted to hear this one. So that's one of the little pluses of Zooming, in that we can record so easily. So thank you very much. And I'll just pause in case any last minute question has come forward.
Not from this end, unless Janet sees anything that's come in directly to her.
No, thank you, Barb and Alberta, for kind words. Wonderful to be in front of you today.
Right. So we will then thanking you, thanking Dr. Koo, and thanking all of our attendees, and we will be sending out a note to everyone and asking just a question or two about the dialogue on aging, but just to say for now that we would normally be having our next having an in-person dialogue on aging in the spring. That would be our normal plan, and so we'll just see how everything unfolds, and if not, of course, we can continue with virtual too. So thank you, everyone, and over to you, Christine, in case you have another point you would like to end with.
No, just lovely to see you all. Stay healthy, and we've got some great recommendations from both of our speakers today, and we look forward to seeing you again soon.
Goodbye, everyone.